As many of you know, the adjuvant treatment of early stage endometrial cancer is very controversial. And I like to use this example just to highlight that point. Let's say a 70-year-old had hysterectomy, BSO, pelvic washing, pathology showed endometrioid, histology, grade 2, 5 out of 12 millimeter of myometrial invasion, no lymphovascular invasion, no cervical involvement, negative peritoneal cytology. What would you do for this patient? Should we do pelvic RT, observation, chemo, and IVRT, any of the above? And the answer is actually any of the above. And you may protest and say, there is no way. Well, let me show you. Is this patient eligible for pelvic RT? Well, based on GOG 99, with their famous or infamous stratification, depending how you look at it, and I hope you get the hint how I feel about their stratification as the talk goes. You are high intermediate risk. I mean, that by itself, like how could you be high and intermediate at the same time? But anyway, it is high intermediate risk if you are grade 2 and 3, outer third invasion. I thought we went away with third of invasion, but anyway, LVI and age. And it's a miraculous combination of any of those factors that make you high intermediate risk. Well, guess what? Our patient make the cut because it was grade 2 and her age was 70. So she is high intermediate risk. And according to the GOG 99 conclusion, this patient should receive pelvic RT. Well, you say if our patient with 1A, old 1B, grade 2, is high intermediate risk based on age 70 and grade 2, is observation an option? The answer is yes. Why? Because believe it or not, this patient would not have been even eligible to be in PORTEC 2, which randomized the patients between intravaginal radiation and pelvic radiation. The reason being, you have to be at a minimum old 1B grade 3 and older than 60 to have made it into PORTEC 2. So if observation is an option, then surely the patient shouldn't be eligible for chemo, right? The answer is no, the patient is eligible for chemo. Here is GOG 249, which just completed, less than a year ago. The patient is high intermediate risk, so she will be randomized to either pelvic radiation or intravaginal brachytherapy and chemo. So if our patient with new 1A, old 1B grade 2 is eligible for such drastically different treatment option, how to decide? I have to say, as far as the role of the radiation is a little bit easier because at least we have some data that have been accumulated over the years. So for example, if you were to look at observation versus intravaginal radiation for patients with endometrioid histology who either have no myometrial invasion or less than 50% myometrial invasion, here is a study from Sweden where they have randomized those patients to either observation or intravaginal brachytherapy. And when you look at the rate of vaginal recurrence, overall very low, 2%. In the group that had observation, it was 3%. In the group that had IVRT, 1.2. Very low number, not statistically significant. The unfortunate part in this study, they did not separate the rate of recurrence for patients who did have less than 50% myometrial invasion as opposed to those who did not have any myometrial invasion. But at least you can make the argument with the new 1A stage limited to the uterus, with grade 1, grade 2 endometrioid histology, observation is a reasonable option. More importantly, the rate of pelvic recurrence was less than 1%. And none of those patients, by the way, had any lymph node assessment, surgically speaking. Well, how about patient with less than 50% myometrial invasion, but grade 3? If you look at the PORTEC 1 trial, which randomized patient to surgery alone versus surgery and pelvic radiation, and if you look at this subset of patient, the 5-year rate of vaginal recurrence was 14%, a big jump. The 5-year rate of pelvic recurrence was 0. So what that tells you that those patients should be considered for intravaginal radiation alone. And again, in PORTEC 1, lymph node assessment was not done. How about patient with more than 50% myometrial invasion, but grade 1 and grade 2? Should it be IVRT, or should it be observation, or even should it be pelvic radiation? If we were to look at the data from PORTEC 1, again, for those who were in the surgery alone arm, the risk of vaginal recurrence was 10% if you are grade 1 and have surgery alone, and 13% if you are grade 2. Again, with pelvic rate of pelvic recurrence, even in patient with more than 50% myometrial invasion, look at the rate of pelvic recurrences, 2% versus 6%. Again, without any nodal assessment. How about those patients now, to say, should it be then IVRT versus pelvic radiation? And that has been an area of great debate in the past. And when we advocated for those patients to have IVRT many, many years ago, even before PORTEC came out, I was called named, this is puff to the cuff, all those patients need pelvic radiation, what are you doing? But anyway, PORTEC trial, again, briefly, this is for patients who are considered high risk, meaning they have to be, if they have less than 50% myometrial invasion, they have to be, grade 3, and they have to be older than 60. And the same for stage, 1C, grade 1, grade 2. Again, no surgical lymph node assessment randomized to pelvic radiation versus IVRT. And what that study showed, that when you look at the rate of vaginal recurrence, which is here, the two curves are identical, so it is not just a puff to the cuff. And when you look at the pelvic radiation, you could see that there is a higher risk of pelvic recurrence in the group that had IVRT alone. However, they mentioned in the study that when you look at the rate of isolated pelvic recurrence, it was identical. In other words, most of the patients who had pelvic recurrence in the IVRT alone arm have simultaneous distant metastasis. And one of the most important findings of this study, which we all expected, that the rate of toxicity was significantly less in the IVRT group compared to the pelvic radiation, especially with regard to GI toxicity. Now, when it comes to the role of chemotherapy, I have to say it is a little bit more challenging because, as many of you know, the result of GOG 249 were negative, comparing pelvic radiation to intravaginal radiation and chemotherapy. And here you see the progression-free survival curve. They are identical. And in fact, some of the local recurrences were higher in the group that were randomized to the IVRT and chemotherapy, but none of that was significant. So what to do? Well, truly, we need better stratification of those patients. One of the unfortunate aspects of this GOG study that I showed you, that probably close to 60% of the patients enrolled were grade 2 endometrioid histology, which, as I showed you before, we were debating whether they need radiation or not. So to make that jump that those patients need chemo, unfortunately diluted, any potential benefit that we might see. And, the issue of high intermediate risk didn't pan out as many thought it would be. So how we can better stratify? Well, based on some of the known risk factor, and now hopefully based on all the genomic data that we are getting in endometrial cancer. PORTEC put their data from the 2 trial as well as the group that they observed. They put them all together and tried to come up with a nomogram. I thought only Memorial does nomogram, but PORTEC did a nomogram. Unfortunately, if you look at this nomogram, they're trying to predict relapse or death within 5 years. I mean, I have never seen a tighter bar for look at the difference between grade 1 and grade 3. I mean, what, you get 2 points? I mean, everything hovering around 0. So even a nomogram from randomized trials in one group did not cut it. We looked at our data. We looked at patients with endometrioid histology only, 728 patients with intermediate high-risk group. And on multivariate analysis, we found age 60 and older, grade 3 endometrioid and cervical stromal invasion to be independent predictor of relapse, death from endometrial cancer, and death from any cause. Then if you take that whole cohort and divide them into those who have 0 to 1 risk factor versus 2 or more, we were able to have some better discriminating power than the GOG stratification. When you look at distant relapse, 5% versus almost 29%. When you look at any relapse anywhere, 9% versus 36. Death from endometrial cancer, 3.5 versus 20. Death from any cause, 8.5 versus 27%. So very, very discriminating. But here is the trick. The group that had 2 or more risk factor represented only 10% of the total patient population. So when you look at this data, it tells you that if you're going to use regular risk stratification, the patient who perhaps would need adjuvant treatment as far as chemo to reduce the risk of distant mets and death from endometrial cancer, you are looking at less than 10% of the patient population. Now, you've all have seen this probably. This is the Nature paper that looked at the genomic landscape. And just brief, I'm not a biologist, so bear with me. This is more for me to understand it better. But, they found 4 groups, as you all know. We start here with the group that has high copy number, the group that has, low copy number, and then those 2 groups here. The one, it's the poly, which, have shown that it has the highest number of mutation. And then the second group, those are the ones that we know about the microsatellite instability. Now, there have been a lot of interest in this group here, because, this is where you are making the jump between endometrioid grade 3 and serous endometrial cancer. So understandably, there is, a lot of interest in this area. But there is also some interest in this area with the patient who have the poly, because they are a little bit unique. In one sense, you could see they have a lot of P10 mutation, which we know is seen in most endometrial cancer. But you look at P53, sorry, I'm losing my arrow. You look at P53, you see some P53 mutation in them. And the way we have understood those things in the past, P53 mutation in endometrioid, cannot happen. You look also at their grade, and you see disproportionately higher percentage of patients who have grade 3 as opposed to being grade 1 or grade 2 endometrioid. So again, this is just for me. So what is this poly business? You guys know about the DNA polymerases. They are adding 1 base at the time, stacking them next to the next template. But they do another job, which is to look back and see if they incorporated the wrong base. So when they are working, they go back, slice it, and start anew. So if you have a mutation in this polymerase, you're going to end up, as you might expect, with a lot of mutation because the printing house is broken. And here, when you see it, here is a representation of some of the known genetic mutation in the poly group, significantly better than the mutated group and those with the copy number low or copy number high. And what's interesting, when the PORTEC group looked at their patient who did have the poly mutation and grade 3 endometrioid histology based on their pathology review, those patients who did have the poly mutation, they have no recurrence, 0. Now, admittedly, those number of patients, when you look at the patient with the poly mutation, they represent about like 6% of patients, with endometrial cancer. So we are dealing with very small number of patients. In fact, here you could see they have only 15 patients who had that mutation. And when they combine their data with other studies that have looked at the poly mutation, and what they found out that indeed this have been shown, not only in the PORTEC study, but as well in other studies where patients who do have the polymutation has significantly better relapse-free survival and disease-specific survival. So I finish with this. This is a distribution of the dose of intravaginal brachytherapy. And here, what you see on the bottom are the genomic landscape. And I hope in the future they will share more than just the color scheme. Thank you very much.